Right. So what we're going to do next, okay, so we're going to do a case discussion. Actually, they're very simple case. I've got two cases, okay, that we have put up for discussion today. Okay, so we will try to be as interactive as possible. Okay, so perhaps I think we can get the participant to maybe put up your answers in the chat for the case discussion. Okay, so let's begin with the case discussion. Okay, so right. So first case, okay, so this is a 16-year-old girl who came to the clinic with a complaint of lesions on the face for 1 year duration. She has tried multiple products bought from retail pharmacy with no improvement. Okay, so that's very common. Okay, so before they come and see us, they will usually try something either from their house. Okay, so you won't be surprised. We have many patients who use cinnamon. Okay, they pound their own cinnamon. Okay, so they put capo. Okay, so a lot of homemade concoction and also retail pharmacy product before coming to see doctor. So she avoids some food as recommended by her mother and friends, but also without improvement. So what other information in the history would you like to elicit? So maybe if I can get you to put in the chat box. Okay, and then I will go through the chat box while we are here. Can anyone put, okay, we have about 1,000 participants here. So what other information would you like to elicit? Okay, menstrual history, diet history. Okay, so there's actually a lot that, oh, okay, I think everybody was concentrating on the lecture just now. So, yeah, okay, so a lot of answers been put up there. So, family history, diet, menses, okay, so what product the patient has been using, whether there's any hirsutism, their menstrual history, okay, lifestyle, okay, so, yep, all those are correct, okay. Good to know that you all are concentrating. Okay. So this would be what we would ask the patient. Okay. So what are the aggravating factors? Okay. So it's already what you all put in the chat box just now. Okay. So whether there's any stress, any usage of new products. Yeah. And I think the one that no one put in the chat box is how does it affect their quality of life? Somebody did? Okay. Yeah. Okay. So I missed that. Okay. So yes, how the acne affect their quality of life. Yeah. Medical history, yes, okay, whether there's any history of a previous acne, okay, so whether the patient has anything to suggest PCOS, yeah, family history of acne, because we know anyone with a family history of severe acne, the chances of getting severe acne is higher. Yeah. Diet, yes, it's very important as what was highlighted by Dr. Lisa earlier. So diet high in high glycemic index, and also this sweetened beverage and food, okay, all those fattening food, they tend to cause exacerbation of acne. Medication history, we know there's certain medication that can aggravate acne, for example, consumption of steroid. Okay, so sometimes we don't even know. With the era of people can buy anything over the internet, a lot of medications being sold and laced with steroid or other medication that may cause acne. Okay, and I'm sure some of you all are aware certain tyrosinase kinase inhibitor can also cause acne. Menstrual history, yep, we want to elicit their menstrual history because we want to know whether they are at higher risk of having a PCOS, okay, and also social history. Right, so this is what is happening with the patient. Okay, so she is actually very stressed because there's exam coming up. She also feels sad, ashamed, and inferior because of the skin lesions. Okay, because as we all know, 16-year-old, okay, and in the era of social media, everybody wants to take selfie, put their photos on the Instagram, whatnot. Okay, so they can get inferior because of the skin lesion. Okay? And a teenager, she likes to drink carbonated beverages at least twice a week. And she also indulged in all these fattening food like donuts and cakes, okay, but dislikes vegetables. Sounds like our kids, right? Okay. So her menses is regular. She is a non-smoker and there's no medical illness. and patient is not on any medication. Okay. Her mother had history of similar problem during adolescence. Okay, so that will probably make us a bit more aggressive because we don't want the patient to have scarring. Right, so now I'm just gonna test your clinical knowledge. Okay, so do you think we can describe what do you see on the picture here? You can type your answer in the chat box. Okay, so comedones, papules, post-inflammatory erythema. Okay, somebody very advanced there giving the grade already, CAS 1. Okay, so erythema, post-inflammatory hyperpigmentation, minimal comedones, box scar. Yep, there's also scarring. Okay, so CAS 1, mild. Okay, box scar. Okay, so I think everyone is on the right track. Okay, so thank you for sharing your opinion and your answer. Let's see whether you're correct or not. Okay, so yes, you can see there's a few scattered comedones, okay, and few papules, okay, some are a bit excoriated. Pustules not very clearly seen, okay, but maybe there's one here, okay, which is already ruptured. Diagnosis, no, nobody's going to argue, okay, this is acne vulgaris, and it's very mild acne, right? Okay, so some of you all have answered before, so maybe we can pass this. I'll go straight to the answer. Or is there anyone else who wants to try? What is the severity? Very mild. You only see a few comedones. Do you think this is CAS 1 or 2? Okay, so we have 1, mild. Okay, I think you're right. Okay, so this patient has CAS classification of 1, which is almost clear. Okay, so it's hardly visible. You see mainly the sequelae of the acne, okay, which is a scarring. There's only few scattered comedones, okay, few small papules, and actually pustules. There's only one that has ruptured. Okay, you can't see an intact pustules. Okay, so this is a very almost clear or CAS 1 severity. Okay. So what are the physical examination would you look for? Okay, so this is a 16-year-old girl. Okay, so any other thing that you want to look for to help with your diagnosis and management? Okay, yep, trunk. Okay, yep, examine the trunk, look for hirsutism, BMI. Okay, so whether there's any androgenic features. Okay, PCOS features. Okay, acanthosis nigricans, Cushingoid, yes, because whether if patient is on exogenous steroid, they can get Cushingoid. Okay, BMI, very good. Okay, so I can see that all of you all have been concentrating on the lectures. Okay, yes, that's correct. Okay, so BMI. Okay, we want to know what is whether a patient is obese or not, and whether there's any evidence of hyperandrogenism, which is a PCOS. Okay. Any investigations would you like to do? Okay, so remember from the lecture just now, should we investigate this patient? Do you think that's required? No need. Okay, no need. Menses history, no need. Anybody wants to do biopsy or swab? Ultrasound? Oh, no need investigation? No need swab? That's good. Not required. Capital. Yes, very good. Okay, all right. Yes. For this patient, because she doesn't have anything to support PCOS or anything, so we do not have to do any investigation. Remember, acne is mainly clinical diagnosis, and in this case, you can appreciate she has mainly non-inflammatory lesions, okay, which are the comedones. Okay, the inflammatory lesions are not much in this patient, okay, but most of acne diagnosis is diagnosed clinically. Okay, so in our clinical practice guideline, we put the recommendation microbiological and endocrinological investigation may be performed to rule out other conditions that mimic acne vulgaris. As you can see from Dr. Evelyn's presentation just now, that sometimes we can't differentiate whether it's a fungal folliculitis or whether it's bacterial folliculitis. So those are the instances when we want to do swab CNS, okay, but not in this case because her acne is very mild. Okay, so are you all doing good so far? Shall we continue with the next patient? Okay, yes, okay. Good. Okay, so but before we continue with the next patient, we will go to the treatment first. Okay, so what are the risks and aggravating factors of acne vulgaris in this patient? Okay, anybody want to type your answer? Okay, female, adolescents. Well, somebody put obese there, but a patient is not obese. Okay, normal BMI. Yep, the fact that she like to eat sweetened beverage and food, all the food intake, family history. Okay, so yeah, I think everybody is putting the correct answer there. Yep. Okay, so age. Okay, so she's in the adolescence age group. So that is the age where there is a higher risk of getting acne, and they may get severe acne in this age group. Stress, upcoming exam, okay, and high glycemic diet, sweetened beverages and food, okay, frequent consumption of carbonated beverages and donuts, okay, cakes, okay. I think most of you all will get asked by patients. Okay, I think the most that get blames is peanuts, right? Okay, nuts intake. Okay, so but from our literature, we found that it's not really associated with that. And chocolate also gets blamed. Okay, but actually, it's probably the um, dairy consumption in the chocolate that causes worsening of acne. Okay, lack of fiber. Okay, so adolescent, they don't eat a lot of vegetables. Okay, so those are the things that can aggravate acne. And the fact that the mother had a history of acne during adolescence. Okay, so those are the risk factors and aggravating factors of acne. Okay, right. So bad diet habits, ultra processed food. Yes. Okay, so ultra processed food, okay, they contain a lot of salt and sugar. Okay, so that can also cause worsening of acne. Right, very good. Everybody's doing well so far. Okay, so now let's look at case 2. Okay, so we only put up 2 cases. Okay, so they are not difficult cases. So these are the one that will probably come to you. Okay, so all the difficult cases you can reserve that to us. Okay, because the more severe cases have to be managed by dermatologists because we need to prescribe them with isotretinoin. Now let's look at case 2. Okay, so case 2 is a 20-year-old Malay female presented with scattered closed comedones, erythematous papules, and pustules on the forehead. Okay, you can see there. On the temples, okay, you can't see because it's covered, okay, and also on the cheeks, okay, so you can see she's got papules, comedones, okay, and some pustules here on the chin, okay. So apart from that, she also has post-inflammatory hyperpigmentation on the cheeks, okay, so you can see that, and also on the chin as well, yeah, way. She has mild seborrhea, okay, so seborrhea is something that we also ask our patients whether and certain patients will say that their skin is oily, but only in certain areas. And most of the time, they will say it's the T-zone that is oily. So this is another profile, the side profile. Okay, so you can see clearly, okay, all the closed comedones. Okay, and she also has a lot of scarring. Okay, so pitted scars, okay, on the cheeks, okay, and also on the forehead. Okay, so you can see post-inflammatory hyperpigmentation, scarring, comedones, and papules. Right, so what would be your answer? How do you grade this patient's acne severity? So is it CAS 1, 2, 3, 4, or 5? Okay, so definitely not 4 or 5. Okay, maybe you can type your answer. Oh, I can see the numbers moving very fast. Let's see whether you're right. Okay, so I see 2, 3, 2, 3, 2, 3. Okay, I'm glad nobody answered 4 or 5 or 1. Okay, so 2 and 3. Okay, so it's a very tough fight between 2 and 3. So what do you think this patient has? Remember, what's the classification for 2 and 3? I think a lot more answered 3. 3 or 2? A lot answered 3, I think, right? Okay, let's see whether you're right or not. Let's see whether 2 or 3 is the correct answer. So now 2 is picking up. Okay, right. So it's a tough fight between 2 and 3. Okay, let's see what is the correct answer. So is it mild or moderate? Okay, it's mild. Okay, all right. So the patient has a CAS 2, which is mild. Okay, so those who answered 3, you're not wrong. Okay, so between 2 and 3, it's debatable. Okay, but why did we put 2? Okay, remember, it's easily recognizable. Less than half of the affected areas involved. Okay, many comedones and papules. Okay, as opposed to 3. Okay, there's more than half of the affected area is involved. There's also numerous. Okay, you can argue between many and numerous. Okay, comedones and pustules. Okay, but if you can appreciate, the area involved is less than half. Okay, compared to 3, where there's more than half of the face that is involved. Okay, but it's not wrong to score between 2 or 3, but I'm happy to see that nobody scored as 4 or 1. Okay. Right, so how would you manage this patient? Okay, so we have A, B, C, D, E there. Okay, so you can type your answer. So would you give the patient topical clindamycin monotherapy? Okay, so alone. Or B, 5% benzoyl peroxide in the morning and adapalene at night. Or C, doxycycline 100 mg OD for 3 months. Or D, tab isotretinoin 20 mg OD for 6 months. Or E, you just reassure this patient that this medical condition is just temporary, okay, and her acne will improve without treatment. So what do you think would be the answer? Okay, so we can see B, C. Okay, let me just scroll from the top. Sorry, majority B. Okay, oh, a lot of answers there. Yeah, we can't screen the 1,000 answers. Okay, but I can see that majority is B. Some answers C. Okay, E. Okay, E. I think you all are just okay. Okay, definitely we have to treat. Okay, we cannot just tell that it's just as part of growing up. Okay, so we have to treat them. Okay, so B, 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 B. So a lot of B team. Some answered C. Okay, so let's see what would be the correct answer. Okay, so A, topical clindamycin. Okay, so not many answer A, but majority is B. Some answered C. Okay. Right, so yeah, I would give this patient topical treatment first because if you remember, she doesn't have much pustules. Okay, so it's mainly closed comedones. Okay, so we can try topical treatment first. If it fails, then only you can add on doxycycline. Okay, so if we remind ourselves again, okay, so patients with mild acne vulgaris. Okay, so predominantly inflammatory lesion, okay, or whether they are non-inflammatory lesion, the first line of treatment is topical retinoid for the non-inflammatory lesion and topical benzoyl peroxide for the predominantly inflammatory lesions. Right. So after using the 2 treatment that we provided, which is benzoyl peroxide and adapalene, patient develops stinging sensation and dryness on the face 3 days after starting topical treatment. Okay. So now she asks you, okay, should I stop the treatment? Am I allergic to the treatment? Okay, or is this normal? Okay, so what would be your answer? Should she stop the treatment, or is there anything that you should tell the patient that they can do? Right, so apply moisturizer, reassure, use EOD. Okay, moisturizer again, sunscreen, EOD, change to intermittent use. Okay, so a lot of people put moisturizer. Okay, so or reduce to 2.5% benzoyl peroxide or use EOD. Yes, it's a good suggestion also. Okay, anything else? Anybody would ask the patient to stop altogether? Use one agent only. Yeah, you can do that. Stop first, apply moisturizer once face better, then only start treatment again. Yep, you can do that. Okay. Right. Okay, sorry. There's actually A, B, C, D, E. Okay. But you've already answered. Okay, so A is stop both topical treatment. Okay, so B, prescribe 1% hydrocortisone cream. C, advise patient to use moisturizer prior to applying. This is what a lot of you all answered, right? Before applying topical treatment and reduce application of topical treatment. Okay, and add on D is add on topical antibiotic, and most of you all answered correctly. Okay, which is use moisturizer or reduce the application, okay, of the topical treatment. Sometimes what I find is doing spot treatment also help. Okay, so you just ask them to apply on the lesions first. Once they can tolerate, then they can apply on the other areas as well. Right, so patient continues with topical BPO and topical adapalene for 3 months with minimal improvement. Okay, so what will be the next best management for this patient? Okay, so we have A, B, C, D, E there. So A, prescribe fixed combination therapy of topical BPO adapalene. Okay, so remember before that patient is on a separate BPO and adapalene. Or is it B, start oral antibiotic with topical treatment? C, start oral spironolactone with topical treatment. D, advise regular chemical peel alone. Or E, refer to dermatologist. Okay, so let's see what's your answer. So B, which is oral antibiotic. Okay, topical treatment. C, spironolactone. E, refer dermatologist straight. Okay. So, but I think majority answer B. C, spironolactone, there's one there. Okay, so I think majority answered B. Okay, there's some who answered C. Okay, but for this patient, the correct answer is B. Okay, so I wouldn't start spironolactone without trying antibiotic first. Okay, so patient does not have any evidence to support hyperandrogenism or PCOS. So antibiotic would be best for this patient together with the topical treatment. Okay, so let's go to the algorithm again. Okay, so mild, moderate, severe. So we've tried the topical, and then when there's no improvement after 3 months, then these are the things that we can offer them. Okay, so if they're not on combination therapy already, they should be on at least 2 topical agents. And then if there's no improvement, then we should add antibiotic, either doxycycline, tetracycline, or erythromycin. Okay, and in female patients with evidence of hyperandrogenism, we can consider hormonal therapy. In our patient, there's no evidence of hyperandrogenism, hence why antibiotic would be the best choice for this patient. So which antibiotic would you prescribe? Okay, so we've already mentioned doxy, tetracycline, erythromycin, or would you give Bactrim or sarecycline? Okay, so those are the treatment that you can give for patients with moderate acne vulgaris, but which would be your choice? Okay, so majority answer A, some answer erythromycin. Okay, C, A, E. Oh, sarecycline is not available in Malaysia yet. Okay, so E definitely we can't give in Malaysia. Okay, but if you're practicing elsewhere, E if available, haha, yes, it's not available. Okay. Majority answered A. All right, so yes, that's what I would give. Okay, so doxycycline. Okay, so Bactrim we try not to give, okay, because we know that Bactrim has got a very high risk of getting drug allergy. Erythromycin, the rate of resistance is very high. Okay, so I would only reserve that for a pregnant patient. And tetracycline, it's a BD dose. Okay, doxy you can give daily. Okay, so tetracycline you have to give a BD dose. So our favorite is actually doxycycline. Okay. So patient was prescribed oral doxycycline 100 OD with topical fixed combination of BPO and adapalene at night. She returns to your clinic 3 months later with minimal improvement of her acne. There are multiple papules and pustules on her face, and she claims to be compliant to oral antibiotic, but not to topical treatment. Right. So what would you do next? Okay. So remember, this patient is already on oral antibiotic and also on the fixed combination, okay, of the BPO and adapalene. Okay. So do you change to another oral antibiotic? Or B, do you advise for chemical peel with 70% TCA? Or C, you continue current antibiotic for another 3 months and change to topical azelaic acid and topical salicylic acid? Or D, discontinue current antibiotic and emphasize compliance to topical treatment? Or E, refer dermatologist? Let's see what is the answer for all. Okay, all want to refer to dermatologist straight. Okay, E. Okay, B, I see B there, TCA. Okay, but please remember for a general practitioner or family medicine specialist, if you want to do chemical peel, you have to be credentialed. Okay, so most of us answer E. D there, which is discontinue antibiotic and emphasize compliance. I don't think so because it's worsening. So don't think we should discontinue the oral antibiotic. Okay, so referral. So C, not that many. Okay, so majority say to refer to dermatologist, right? Okay, but actually some do answer C, continue current antibiotic for another 3 months and change to topical azelaic acid. Yes, that could be an option. Okay, but okay, let's see what would be the best for this patient. Okay, let's look at our algorithm again. Okay, so yes, if no improvement, I think no need to waste time to try on the other options. Okay, so it's time that patient may need other modalities because you remember that chemical pills and all that can only be provided by credentialed practitioner. Okay, so you need to have an LCP, okay, to do chemical peel, and isotretinoin can only be prescribed by dermatologists, and laser treatment and all that has to the practitioner have to be credentialed before they can offer such services. Okay, so the best answer would be just refer to us. Okay, so we will treat the patient appropriately. Okay, so with that, okay, they are very simple case. Okay, they're the cases that you're going to see in your daily practice. Okay, so we didn't put the severe cases because most of the severe cases are managed by us anyway. Okay, so hence the reason why we put up those two simple cases, right? So we've come up to the end of the clinical presentation.